Good morning, consultants and fellow senior registrars, resident and medical officer. Today we'll be having a case presentation, and the title of the case is The Role of Health Education in the Management of Acute Pyelonephritis. So biodata, the name, FO, age 30, sex, female, occupation and accountant, religion, Christianity, address, lives in Apo, Zone E to be specific, marital status, patient is single, so Figo tribe, hospital number 144538, date of admissions 9th of January 2024, date of discharge 18th of January 2024. Informant is patient. So presenting complaints, abdominal pain of 2 days duration, vomiting of a day duration, history of presenting complaint. FO was well until she presented with a 2-day history of abdominal pain. The pain was located in the lower abdomen and was sudden in onset, persistent, and progressively worsened. It was sharp, intermittent, and of high severity, with a pain score of 8 over 10 and radiating to the lumbar region and back. There was no non-aggravating or relieving factor. She had no previous history of similar pain. FO was FO was unable to carry out any activity during each episode. Vomiting started a day before presentation. She had 2 episodes and vomited recently ingested meals. Vomiting was not bilious, projectile, or blood-stained. There was no change in bowel habit. She had no painful urination, change in urine color, or vaginal discharge. There was no fever. Because of the above symptoms, she bought diclofenac from a drugstore with no improvement in symptoms, hence her presentation to the hospital. Hefo was afraid as a result of the severe pain. Hefo was afraid as a result of the severe pain because she thought there was ongoing major damage to her internal organs, and she was unable to carry out her daily routines and feared she would, and she hoped to receive relief for her symptoms. Review of systems: there was no history of convulsion, loss of consciousness, or lethargy. There was no cough, difficulty in breathing, autopnea, or cyanosis. Past medical history, there was no previous history of medical illness. She had a myomectomy in 2020 and a lumpectomy at the back in 2021 with no post-operative complication. There was no blood transfusion history. She had a history of self-medication as FO usually purchased over-the-counter medications anytime she was sick. Gynecological history. FO had a regular 30-day cycle and a menstrual flow of 5 days. Her last menstrual period was 29th of December 2023. She had history of dysmenorrhea but no menorrhagia or intermenstrual bleeding. She had not done a pap smear before. Family and social history. FO was the first child among 3 sisters born into a monogamous family. She was from a functional family with ABGA score of 9 over 10. She was single and lived with one of her sisters in one-bedroom apartment in Lugbe. Her apartment was well ventilated, netted, and she used bowl as a source of cooking and drinking, and a water system for sewage disposal, and used a gas cooker for cooking. There was no history of alcohol consumption or smoking. Hefo was working as an accountant in a private establishment in Abuja with a monthly income of 189,000, and a source of healthcare financing was out-of-pocket expenditure. Drug and allergy history. She had no known allergy. I was not on any medication. General examination. At presentation, Hefo was conscious but in painful distress, pain threshold of 8 over 10, and was febrile with temperature of 38.3 degrees Celsius. She was not pale, anecteric, cyanosis, or dehydrated. She had no pedal edema. Her weight was 70 kg and her height was 1.5 8 meters with a BM of 28 kilogram per meter square. Abdomen. Her abdomen was full and moved with respiration. It was soft on palpation with suprapubic and left lumbar tenderness. There was positive left renal angle tenderness with no scar tenderness or organomegaly. Her kidney were not palatable and bowel sounds were present and normoactive. Cardiovascular system. FO had a pulse rate of 112 and blood pressure of 101 over 58. Her heart sounds were extra and S with no murmur. Respiratory system. She was not dyspneic with a respiratory rate of 16 cycles per minute, saturating at 98%. There was equal chest expansion and the chest was clear clinically on auscultation. Wo- Provisional diagnosis was acute pyelonephritis. Differential diagnosis of dysmenorrhea, left ovarian cyst torsion. Psychosocial problems in FO, poor health-seeking behavior, that is self-medication, overweight according to the BMI. The management. FO was given an analgesic injection, diclofenac 25 milligram start to relieve pain and fever. She was counseled on examination finding possible diagnosis and treatment plan to which she consented to. As samples were taken for analysis, full blood count, EUC, and abdominal ultrasound scan was also requested. She was commenced on IV fluid normal saline hourly, 1 liter, IV levofloxacin 500 milligram daily, IV iosine 10 milligram 12 hourly, and IV paracetamol 600 milligram 8 hourly. Bedside urinalysis showed blood of 3 pluses, protein 1 plus, nitrite 1 plus, leukocyte 3 pluses. Full blood counts show marginal elevation in WBC with neutrophil predominance of 73.6%. PCB was 39%, platelet was 355. EUCR was essentially normal. Ultrasound result reported no abnormality. A urine MCS was also requested while on admission as she had her siblings with her, which were a source of comfort and support for her. Second day of admission, if we continued the above treatment, she had some clinical improvement. However, she was still having intermittent abdominal pain and fever despite analgesia. Fourth day of admission, the result of urine MCS yielded heavy growth of E. coli, sensitive to only meropenem, and resistant to all antibiotics, including ceftriaxone, levofloxacin, ciprofloxacin, augmentin, and cefixime. FO was counseled on the result of the urine MCS and the need to change antibiotics to meropenem, to which she gave consent. She was commenced on IV meropenem 100 milligram Italy and levofloxacin was discontinued. Fifth to ninth day of admission, she completed 5 days of IV meropenem with complete resolution of symptoms. Repeat urine culture was requested and she was discharged on the ninth day of admission. She was scheduled for follow-up in 5 days. FO was educated on the right health-seeking behavior and its benefit. She was also educated and counseled against self-medication and other poor health-seeking behaviors. She was shown the negative health implications that could arise from self-medication, such as antimicrobial resistance and damage to other vital organs of the body. She was also advised to purchase health insurance to ensure that she had access to good health hospital services when the need arose. She was counseled on the management of dysmenorrhea. She was asked to commence oral mefenamic acid 500 milligram TDS 2 days before the onset of menses, as this will help with pain control. She was also counseled on weight reduction via dietary restriction, regular exercise. She was also counseled on general female reproductive health, such as contraception and pap smear for cervical cancer screening. She was subsequently still on follow-up on the fifth day after discharge. The result of her urine MCS were reviewed and was found to be normal. FO was again counseled on right health-seeking behavior and the danger of self-medication, getting enrolled in health insurance to which she assented to. By this time, she had already made plans to enroll with one of the HMOs. Discussion. Acute pyelonephritis is a bacterial infection causing renal inflammation and is one of the most common kidney disease. Pyelonephritis generally occurs as a complication of an ascending urinary tract infection, which spread from the bladder superiorly to the kidney, although the infection may be spread hematogenously. The route of infection was not clear in the case of FO as there was no prior history of UTI before the onset of symptoms. Acute pyelonephritis in the United States is found at a rate of 15 to 17 cases per 10,000 females and 3 to 4 cases per 10,000 male annually, with annual total of 250,000 cases annually reported in the United States. The preference for female gender is consistent in FO. Risk factor for pyelonephritis are the history of UTI, extremes of age, infant and elderly, pregnancy, and immunosuppressive state, and none of these risk factors were elicited in FO. Acute pyelonephritis can be divided into complicated and uncomplicated types. Complicated pyelonephritis includes pregnant patients with uncontrolled diabetes, kidney transplant, urinary anatomic abnormalities, acute or chronic kidney failure, as well as immune-compromised patients. Also, pyelonephritis can also be acute or chronic. If we had acute uncomplicated presentation, symptoms usually include fever, flank pain, chills, nausea, vomiting, anorexia, burning or urination, increased frequency and urgency. The most common acute pyelonephritis symptoms are usually fever and flank pain as observed in FO. As, as observed in FO, physical examination finding were fever with costovertebral and suprapubic tenderness. Just like in FO, diagnosis is usually clinical and confirmed with a urine analysis and culture. Observed in FO, E. coli, Escherichia coli is by far the most common cause of acute pyelonephritis and and most other urinary tract infection. Klebsiella pneumoniae is the second most common causative organism, followed by Proteus, Pseudomonas, Enterococcus, Staphylococcus, and other enterobacteria. The mainstay of treatment of acute pyelonephritis is antibiotics with analgesia to deal with fever and pain. It is it is recommended to start the patient on empirical antibiotics in line with the local antibiogram, such as cephalosporin, fluoroquinolone, or sulfametazole triametoprene. FO was commenced on IV level fluoxetine initially. However, she had to be switched to meropenem due to antibiotic resistance. Common complications resulting from acute pyelonephritis are acute renal failure, chronic pyelonephritis, obstructive pyelonephritis, renal abscess, renal scarring and atrophy. None of these were observed in FO. Health-seeking behavior is defined as the way people monitor their bodies, define and interpret bodily indications, make decisions about needed treatment, and use formal and informal source of care. It is any activity undertaken by an individual who perceive themselves to have health problems or to be ill to find appropriate remedy. Factors that influence individual health-seeking behavior are family support, finance, religious beliefs, age, gender, literacy level, poverty, cultural/prevalent societal practices, and health system factors. The presence or absence for any of these factors will impact the health-seeking behavior of individuals. For health-seeking behavior was poor. FO health-seeking behavior was poor due to lack of health insurance, social practices, and norms that encourage self-medication and weakest health institutions that permit poor health-seeking behavior. The recommendation that foster good health-seeking behavior includes government intervention, investment in healthcare, and the use of policy to dissuade negative health-seeking behavior. As 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 was done for FO, health education and counseling by health workers are also critical in bringing about societal enlightenment. Lesson learned from this case: family physicians who are trained in the art of holistic management of patients should be seen investigating the underlying problem behind the patient illness and addressing them properly to reduce patient morbidity and mortality in the long run. These are my reference. Thank you for listening.